So our next speaker is Professor Vittal Katikireddi. Vittal is a Professor of Public Health and Health Inequalities and a Senior Clinical Research Fellow at the University of Glasgow, and also an Honorary Consultant in Public Health at NHS Health Scotland. Vittal's research aims to improve our knowledge about the social determinants of health and to identify approaches to both improve population health and to reduce health inequalities. He has co-authored multiple papers on the unequal impact of COVID-19 over the course of the pandemic, and is a member of both the Scientific Advisory Group for Emergencies, or SAGE, so the advisory group to the government in the UK, the subgroup on ethnicity, and also a co-chair of the Scottish Government's expert reference group on ethnicity and COVID-19. We're really, really delighted to hear Vittal's views on what we know so far. Thank you.
Thanks very much for the invitation. It's great to be able to speak to you all today. Hopefully hopefully you can all see my screen at the moment.
Yes, we've got that, thank you.
Excellent, great. Okay, so just to kick off, as mentioned, I've got a couple of declarations of interest, and to note that what I'm going to say today is very much my own views as an independent academic. It doesn't reflect kind of any separate organization or anything like that. So if we think back to the start of the pandemic, you might remember there was this often said phrase of "we're all in this together." And everyone from kind of leading supermarkets to leading pop stars like Madonna said this. But the reality is, as the pandemic's unfolded, it's become quite clear that actually we're not all equally in this together. So while some people have had, in some ways at least, a very good pandemic, so Jeff Bezos, for example, has famously gained 115 billion in value over the pandemic. For many other people, they've actually experienced real economic hardship, but also really substantial risks. And what I'm going to try to illustrate is how some of those risks have disproportionately affected ethnic minority groups, and try to give you a framework for thinking through why that might be. So if we think about the UK in particular, whenever we look at kind of international comparators, we've often seen that the UK has tended to have a relatively poor performance, at least in relation to COVID mortality. There are obviously lots of other graphs that could be drawn, but generally when we're looking at kind of mortality risk related to COVID, the UK tends to come close to the top of the league table. And until quite recently, with the excellent rollout of the vaccine programme, there'd been, arguably the UK hadn't been having a particularly good pandemic. And some of the reasons for that, I'd suggest, actually lie with some of the things that were happening in the UK prior to the pandemic. So actually, before the pandemic, we experienced a decade of austerity where a lot of public services had experienced cuts, including the NHS, and so were maybe a bit less resilient and able to cope with the threats the pandemic exposed. And that includes, importantly, local government as well. And linked to that, we also saw in the UK, actually, that life expectancy had begun to stall. So in contrast to many other high-income countries, often with better life expectancy than the UK's, which carried on experiencing an improvement in life expectancy, in the UK, life expectancy had started to tail off, and we also had other competing political priorities going on, such as Brexit. And these factors meant that perhaps when the pandemic came along, the UK wasn't really paying attention to the real health crisis COVID turned out to be. And some of these pre-pandemic factors are particularly important because they have probably affected specific social groups disproportionately. So the stalling of life expectancy and the people experiencing austerity have often tended to be poorer, and also often tended to be women and disproportionately ethnic minority groups as well, although the data by ethnicity are probably more limited. So when the pandemic hit, we saw very early on that often COVID-related deaths were higher amongst many ethnic minority groups. So everything above the horizontal line here reflects a greater risk of dying from COVID. And this was from back around March, April last year, these data. And interestingly, that pattern is actually a bit different from what had happened pre-pandemic. So these data are from Scotland, where a few years ago, we looked at what mortality rates were like in Scotland by ethnicity. And as you can see, for several ethnic minority groups, there was often a lower mortality risk, so below the horizontal line, or at worst, a kind of comparable mortality risk to the white Scottish group. And that is also reflected in English data as well. So this is from Professor Fenton's report. And here you can see that actually not only was there an increase in mortality risk during the pandemic, that increase was much greater amongst ethnic minority groups than in this case, the white group. So there's potentially different stages where, at least for direct harms related to COVID, different stages where that risk might occur. It could be the case that ethnic minority groups are being disproportionately exposed to the virus. They might be then more likely to develop clinically important disease, and then potentially have a poorer prognosis following experiencing disease. And then amongst people who recover, it's possible that the social consequences of having had disease might differ as well. So I've spoken a bit about ethnicity already, but I think it's worth just briefly pausing to think about actually what do we mean by the term, and how does that differ by the similar concept of race that's often it's often confused with. So the concept of race historically has tended to assume there were marked biological differences amongst humans, even to the extent of thinking about subspecies of humans, and race as an idea was based on visible physical characteristics with the inherent assumption that there would be marked genetic differences across different races. In reality, what we've seen as scientific understanding has improved over the centuries is there's very limited support for the concept of there being genetically distinct races. But actually thinking about race can still be useful if we're interested in understanding experiences of racism. So if we're interested in understanding how people who might look different in different ways might be treated in society, and that then might impact on their health. In contrast, the concept of ethnicity is often based on identification, preferably by an individual themselves, and it includes, as well as the physical features traditionally associated with race, it includes issues of language, diet, religion, and other cultural factors. So it's a much more holistic term, as it were, that explicitly draws attention to the different dimensions that might impact on health ultimately. A few points about terminology. So often there's a concern that that there's a tendency to think that the experiences of all ethnic minority groups might be similar, and all their health outcomes might be similar, but actually there's often very marked heterogeneity, so very marked variation across ethnic minority groups in the UK in their health experiences. And it's also important to avoid the tendency to assume biological differences as the main explanation for health differences. There are some situations when there might be important genetic differences, but they tend to be rare and related to very specific rare diseases. So what I've hopefully tried to convey is we can think about ethnicity as quite a multidimensional concept, and that then there then might be a range of quite complicated multiple mechanisms, as Professor Fenton was indicating, that then might ultimately lead to differences in COVID-related outcomes. And those differences in outcomes might relate to differences in exposure to the virus, picking up severe disease, and then harms as a consequence. Importantly, the mechanisms are quite likely to be underpinned by structural racism. So what I'm trying to get at there is if we're thinking about, for example, occupation as a potential mechanism. So we know, for example, many ethnic minority groups might be in lower paying work that's more front-facing in terms of interacting with the public, and might be more likely to be in insecure employment, so not having a secure job contract. So, for example, a 0 hours contract. The reason for people ending up in that situation might often be these broader structural forces of related to racism. So that's not to deny the importance of occupation, but that occupation then is a mechanism for some of these broader issues. So if we think about those different stages of disease in relation to being exposed to the virus, the ONS has carried out serological studies of a random sample of the population in England. And what they found through looking at antibody testing, so trying to find evidence of previous infection, is that it's often the case that ethnic minority groups have been more likely to show evidence of previous infection, and by implication might have been more likely to have been exposed to the virus. So we don't yet know if that actually might be a major stage in the disease process at which the excess risk arises. Or in fact, it might even be the case that that might account for all of the excess risk, but it's still a bit unclear about the relative importance of that stage. And then when we look at ending up in hospital, we've often seen people from ethnic minority groups are often then more likely to be in hospital. And this is a slide from fairly early on in the pandemic, but I wanted to flag up a couple of things here. So firstly, you can see that some ethnic groups that are often combined together. So if we think about South Asian groups, we often would include Indian, Pakistani, and other South Asian all within one group. We often see quite big differences even within that, that broader category or in the risk of ending up in hospital with COVID. And the second thing I wanted to flag up is that social factors seem to be potentially quite important in trying to explain the greater risk. I should point out that in this particular analysis, actually the measurement of social factors wasn't that great, but even so, it did seem to have a bit more explanatory power than some of the other factors that were looked at. And when we look at the situation as it's evolved over time, As you can see, and as Professor Fenton showed earlier, there's been an ongoing, there's evidence of ongoing inequalities. So on the left-hand side, you can see the patterns in the first wave. On the right-hand side, you can see the patterns in the second wave. And generally speaking, there's persistent inequalities in the risk of ending up in hospital here with COVID. So, as I've said, it's possible that ethnic minority groups might experience a difference in the risk of coming into and being exposed to the virus, a difference in the vulnerability to severe disease, and difference in prognosis. But it's also possible that some of the things that we do might result in a difference in risk as well. So just to unpick in a bit more detail this idea of differential exposure, so it's possible that in addition to certain risks being more common amongst ethnic minority groups, it's possible that actually the effect of those risks might even be greater amongst some ethnic minority groups. So to give you an example of that, if we think about occupation as a risk factor, if we compare the white non-essential workers to these different groups, you can see that being an essential worker was associated with a greater risk of severe COVID, but actually being a non-white essential worker was associated with an even bigger risk of being hospitalized with COVID in this study. So it's possible that, for example, the difference in accessing PPE might affect all healthcare workers, for example, in the early phase of the pandemic, but might have affected non-white people to a greater extent. So just to try and unpick this framework a bit more, as we've tried to understand the different stages of the infection process, one area that might be quite important is thinking about what we as public health practitioners do and also what policymakers do. So a really important thing that has been a really great success has been the vaccination program as a control measure. But as Professor Fenton noted, actually there's been quite marked differences in willingness to take up the vaccine, and it's required a real concerted effort to try to address some of this vaccine hesitancy. So quite early in the pandemic, so these data from late November, you can see that there was really quite high rates of vaccine hesitancy early on, but as Professor Fenton noted, some of that hesitancy has thankfully started to tail off. The other thing to note again is the massive heterogeneity in vaccine hesitancy we're seeing. So it's not the case that all ethnic minority groups have very high rates of hesitancy. Actually, there's a very large variation in terms of hesitancy. So going on then to think about what's been happening during the pandemic, in addition to the really important direct harms arising from COVID-19 disease, we've also seen necessary stringent policy responses to tackle uncontrolled infection. And those policy responses themselves might impact negatively on health and health's determinants. So I apologize for this slightly complicated slide, but the key take-home points here are you can see the risk of COVID-19 direct harms in purple on the left, but actually there's also a whole host of indirect consequences of the pandemic that have been happening as well. So we know about the issues of educational disruption, issues of employment disruption, home isolation, and also the healthcare system itself has also been impacted both by the need to actually tackle and respond to high infection rates, but also diminished capacity as well. So one thing we've recently been looking at is trying to understand how has healthcare been disrupted and who actually has been affected most by healthcare disruption. So in this work, as part of the National Core Studies initiative, we've been looking partly at electronic health records across the three nations of Great Britain, but also looking at existing rich longitudinal data sets. So to investigate inequalities in healthcare disruption, we've brought together 12 existing population-based longitudinal studies and tried to look at what predicted self-reported healthcare disruption and were there important inequalities by ethnicity, but also across other dimensions. And when we've done that, what we've seen is actually non-white ethnic groups have experienced greater healthcare disruption than white ethnic groups. And this is for reporting any form of healthcare disruption, but we see broadly similar patterns for when we're looking at access to primary care and elective procedures and receipt of medications as well. Earlier, someone asked about mental health, and as we've seen quite early in the pandemic, there was really marked deterioration in mental health, especially during the first lockdown period. And what we noticed at that point was some ethnic minority groups seem to have been disproportionately affected by that mental health deterioration. At the moment, however, there's still quite a lot of imprecision around those analyses, and so we're planning to do further work to actually investigate how mental health has evolved over the course of the pandemic, not just in the earliest period, and also how it's affected different social groups. So coming up to the end then, as we're looking forward to what happens in the future, one of the real threats we're experiencing at the moment is the potential for some form of economic crisis. And that itself might have quite marked impacts on health, including for ethnic minority groups. So as we've seen in the past, many ethnic minority groups tend to be disproportionately in insecure employment and therefore might be at greater risk of experiencing job losses or loss of income. And we know that both job losses and loss of income is quite strongly related to health. There's also the possibility that actually many people have experienced delays in important life transitions, and those themselves might impact on future health. So issues like entering the job market or leaving home for young people, delays in those processes might have quite important long-term consequences. As we've seen in relation to healthcare disruption, there's been some real experience of lack of access to healthcare, which might then ultimately lead to longer term disability due to not having received timely, effective healthcare, but also as a result of the high levels of infection, there's a risk that long COVID might itself impact on people's long-term health. So all of these future issues, as we're thinking about how to build back better, there's a risk that ethnic minority groups might be disproportionately impacted. So we really need to make sure that we think about all dimensions of inequalities as we move forward. So including thinking alongside socioeconomic, gender, disability, and age issues, making sure that ethnicity is included amongst that. So I'll stop there, and I think we'll have questions a bit later on.
Yes, thank you very much, Vittal. Yes, any questions you've got at all, please put them in the Q&A, and we will ask them after our next speaker's talk. So that leads me on to introduce our third speaker, who is Professor Clare Bambra. Clare is a professor of public health at the Population Health Sciences Institute of Newcastle University. Here, Clare's research focuses on understanding and reducing health inequalities. She's a director of the Equal England Health Inequalities Knowledge Exchange Network, and she also leads a Wellcome Trust grant investigating the North-South health divide. That's a bit of a mouthful. Clare has led multiple reports on the unequal impact of the pandemic, including the independent SAGE report on COVID-19 and health inequalities. We're very fortunate to get to hear Clare's insights on her talk titled The Unequal Pandemic, COVID-19 and Health Inequalities. Thank you very much, Clare.
Thank you very much for that kind introduction. Hopefully you can see my slides.
Yep, looking good.
Excellent, thank you. Good afternoon, colleagues, and thank you to the Centre for Personalised Medicine for arranging this really important session today about health inequalities. I'm going to talk about how the COVID-19 pandemic is an unequal pandemic, building on some of the points made by Professor Fenton and Professor Katikireddi already, but drawing out a little bit more some of the historical context and introducing a couple of concepts around the syndemic pandemic. So I'm going to talk about very briefly what the inequalities in COVID-19 are, because we've seen some of them, particularly in relation to Black, Asian and minority ethnic groups, but I'm going to expand that a little bit, particularly to talk around some of the geographical inequalities. I'm going to place that in a historical context, looking at what we know from past pandemics, particularly the 1918 Spanish flu pandemic. I'm then going to introduce the concept of a syndemic pandemic, and I'll talk through some of the pathways to inequality, which colleagues have already alluded to. I'll then touch a little bit upon the unequal vaccines and whether we're seeing evidence of the inverse equity hypothesis. And then I'll talk through some of what I see as the future issues about the economic crisis that may be on the agenda and how that impacts on inequalities, and crucially, what we can do to reduce these inequalities through social and political action. And I'll conclude thinking through the role of public health and the wider health and care community. So we've talked quite a lot so far today about the really important ethnic inequalities that the COVID-19 pandemic has shown, not just in terms of COVID-19 itself, but also in terms of health inequalities that existed amongst these groups before the pandemic. On top of that, we can also think about other axes of inequality, and one of the most important is around deprivation. And this data here is showing how in England, the gap in COVID-19 mortality between the 30% most deprived neighbourhoods and those that are the least deprived, the most affluent and the poorest, is over double. And to put this into some context in terms of the figures, then we can see, for example, that in Scotland, the COVID-19 death rate over the year March to May between March 2020 and May 2021 was 86 per 100,000 in the most deprived 20% of neighbourhoods, which was more than double that of the 38 per 100,000 in the least deprived. And there's similar ratios in terms of England and Wales. It was also noted significant regional inequalities and a clear north-south divide emerging in terms of COVID-19. So the maps here are showing mortality rates for COVID-19 for the 12 months between March 2020 and February 2021. And you can see all-cause mortality and COVID-19 specific mortality. These highlight very high rates, for example, in London, but also particularly high rates, particularly in urban areas of the Northwest and the Northeast. And work that I was involved in with colleagues from the University of Manchester and the Northern Health Science Alliance has found that the mortality gap in the first wave between the northern regions and the southern regions was over 12 deaths per 100,000. We've also conducted some more recent analysis, which suggests that there is also an inequality gap between areas of high deprivation in the north compared to areas of high deprivation in the south. And so the red bars here are showing COVID-19 mortality rates are much higher in northern deprived areas than in southern deprived areas. So in addition to the inequalities around deprivation, there's also a regional perspective which we need to take into account, particularly in terms of how we address the pandemic and how we go forward to build a more equal country. Professor Fenton alluded to some of the data around occupational inequalities, which again is an intersecting aspect of the broader inequalities that we're seeing in COVID-19. This is the latest data from the ONS looking at mortality rates from COVID-19 amongst working age men and women, taken from March through to December last year. And as we can see, there's a fairly clear social gradient. So people in more managerial and senior roles have a much lower mortality rate than people in more elementary occupations, people in plant machine operatives, and particularly people working in caring, leisure and other service occupations. I won't dwell too much on this, not because it's not important, but because we have had two speakers who have gone into it in great detail and with far higher expertise than myself. But this is just to reinforce what they've said. With this is some of the latest data available from Public Health England showing this really high mortality rates in terms of Black, Asian and minority ethnic groups compared to white or white British, not forgetting, of course, the diversity within these groups. But clearly, this is the biggest inequality that the pandemic has exposed. The second part, I want to try and put these inequalities that we're seeing in COVID-19 into a historical context. In a sense, they're not unexpected. We have seen this before. Not only do we see it in terms of other health outcomes when we look at all-cause mortality or specific mortality causes today, but we can also see these patterns of socioeconomic and regional inequalities, particularly when we look into our recent history. So, for example, historical data from Norway, Sweden and the United States shows that there were significant inequalities in the Spanish flu epidemic. There was higher incidence of mortality amongst, for example, the working classes of Chicago, unemployed in Norway, and lower occupational groups in Sweden. English and Welsh data shows particularly high urban-rural divide in 1918, with mortality up to 40% higher in urban areas. Again, a pattern that we see reflected in the COVID-19 pandemic today. I was recently involved in some work with a historian, Niall Johnson, who's an expert on the Spanish flu pandemic, and a geographer colleague from University of Leeds, Paul Norman, looking at what the regional impact of the 1918 pandemic was. And as the map on the right shows, you can see a very clear spread in terms of much higher rates of mortality in 1918 in the northern regions and in Wales down to the Midlands, and lower rates in the south, southwest, southeast and East Anglia, partly reflecting the urban-rural divisions, but also reflecting occupational and other inequalities present at the time. And to give an indication of the extent of the inequalities, the table shows those parts of the country in 1918 that had the highest death rates from Spanish flu. So, for example, Hebburn and Jarrow in Durham in the northeast, where I work, had mortality rates at over 1,000 per 100,000. In contrast, parts of the country in 1918 that had the lowest rates were as low as 200 or so in places such as Surrey. So the geographical inequalities we're seeing today were also present in 1918, albeit much more stark, with much higher overall mortality rates across the country. We can also see these socioeconomic inequalities when we look at the more recent H1N1 swine flu pandemic of 2009. Data here from Rutter and colleagues found that mortality in England was 3 times higher in the most deprived quintile compared to the least deprived quintile of neighbourhoods. Again, higher in urban compared to rural areas. And international data also found this pattern when, for example, Canadian researchers looked at H1N1 hospitalisation rates. They found they were associated with lower educational attainment and geographical deprivation. And similarly in the United States, hospitalisations were positively associated with people experiencing financial issues and debt. So again, in this more recent pandemic, we can see the extent of these inequalities. Together with colleagues from the School of Public Health Research and the applied research collaborations across the country, I was involved in a piece of work trying to conceptualise why we're seeing these inequalities, not just today in terms of COVID-19, but also in these pandemics of the past. We drew on the concept of a syndemic, which is associated and conceived by the anthropologist and clinician Merrill Singer. He defined a syndemic as a set of closely entwined and mutually enhancing health problems that significantly affect the overall health status of the population within the context of a perpetuating configuration of noxious social conditions. Merrill Singer is a clinician and an anthropologist, and his research in the 1990s was examining the syndemic, so the close interaction of epidemics of HIV, drug use and violence in urban areas of America. And in contrast to other colleagues who were looking at these as separate epidemics, he argued that they were so closely entwined and mutually reinforcing that they need to be considered as a syndemic. We applied this syndemic concept over to the COVID-19 pandemic, trying to think through some of the pathways whereby interactions between the different social, economic and environmental determinants of health interact with existing higher burdens of NCDs amongst more deprived communities to come up with pathways whereby we see the inequalities that we see within the COVID-19 pandemic. And we drew upon the famous Whitehead and Dahlgren rainbow model of the social determinants of health to produce this figure which tries to conceptualize the interactions between various aspects of life and society and people's experiences and how these play out in this syndemic pandemic. We've suggested at least 4 pathways to inequality, some of which have been touched upon by the previous speakers. The first one is around increased vulnerability. So when we think of why more deprived neighbourhoods have higher rates of COVID-19 morbidity and mortality, then we can link this to the clinical risk factors, higher rates of NCDs such as diabetes, obesity and respiratory illnesses that are present within these communities. In turn, these are related to the unequal exposure over the life course of these communities to the adverse social determinants of health, for example, childhood experiences, housing, or lower education. The second pathway is around increased susceptibility, and this draws on research into seasonal flu, which internationally has suggested that immune systems can be weakened by long-term exposures to adverse living and environmental conditions, meaning that infections are more likely to lead to hospitalizations and deaths. The third pathway is around exposure, and this particularly touches upon within the COVID-19 pandemic, but also in 1918, looking at inequalities in working conditions to which different communities are exposed. A classic example, perhaps reflected in the occupational data that I demonstrated, is the ability to work from home or not during the last year. A second element is a financial one in terms of whether people are able to self-isolate if they have symptoms or whether they are unable to afford to do so. These are inequalities in working conditions which are impacting on the inequalities we're seeing in COVID-19 spread. The fourth one is around increased transmission. And this is where we need to think about inequalities in housing conditions and in neighbourhood green space, and to think about how difficult it is to isolate yourself and to protect your family if you're in a smaller property or you are living in a more overcrowded environment. We can also see this in terms of the urban-rural split, where it's much harder to restrict the spread of an infectious disease within more highly populated areas. And a final aspect to think about is around the inequalities that we experienced during the lockdown, whether you had access to green space within your community or not, in terms of your ability to exercise safely and to reduce transmission when doing so. So there are at least 4 pathways to inequality, which the idea of the syndemic pandemic helps us to think about, but all of them relate back to underpinning pre-existing inequalities in the social determinants of health. So in a sense, COVID-19 is following the patterns that those of us in the health inequalities field would unfortunately expect to happen, and which historical data tells us would happen without intervention. Perhaps a 5th pathway that now needs to be considered is around the role of the vaccination rollout, which of course is an absolute fantastic success, but we need to always be mindful, as Professor Fenton described, about inequalities in the uptake and access to the vaccine. And here we need to think, I think, about a concept of the inverse equity hypothesis. And this is developed in relation to medical technology use, particularly with, for example, work done in Brazil, suggesting that as new technology, new drugs, new treatments appear, it's the more affluent groups of society that are more likely to take that up quickly, increasing inequalities through the innovation. And perhaps the vaccines represent a new example of this inverse equity law. As we can see here, looking at deprivation, we can see that the most deprived is around 7 percentage points lower than the most affluent neighbourhoods. And as colleagues have talked about, there are very significant yet pleasingly closing gaps in terms of vaccination uptake across different ethnic minority groups. But here, perhaps we need to think about this again as part of a wider programme of work that we in the health and care community can think about, not just in terms of COVID-19, but to see this as a prompt in terms of how we develop and deliver all of our medical and public health innovations. Vittal, in his previous talk, touched upon the looming economic crisis and the impact that this could have on the life chances and health of Black, Asian and minority ethnic groups. I want to step back a little bit and think about that in a broader context as well, to touch upon some of the geographical impacts that this could also have, which of course intersect with issues of ethnicity. So we saw over the last year record levels of unemployment, particularly, for example, during April last year in the USA, over 5 million people filed for unemployment benefit in just 1 week. And there are predictions in the UK currently that once furlough ends, the unemployment rates could rise to 10%. We're already beginning to see increased rates of child poverty. And over the last year, the rate in Middlesbrough in the northeast of England now stands at around 40% of children living below the poverty line. Economists have speculated that the economic impact of COVID-19 will be far greater than the global financial crisis and possibly worse than the Great Depression of the 1930s. And indeed worth noting that the Great Depression of the 1930s had a much more impact on the north of England than the south of England. Perhaps these are geographical inequalities which may happen again, but hopefully we'll be able to intervene to avoid them. At the moment, the furlough schemes are providing some protection against this economic shock. In terms of the health impacts of an economic crisis, then we have data to tell us that this is generally going to be a poor time for public health unless there is significant intervention. This is some work I was involved in, led by David Taylor Robinson from the University of Liverpool, which charted trends in child poverty rates shown in the blue line, and infant mortality rates. And infant mortality rate has unprecedentedly increased since 2013, and this broadly patterns increases in child poverty. So we can see how these economic indicators, in a sense, are the canary in the mine in terms of future health indicators. We're already beginning to see some geographical inequalities in the impact of the economic crisis, and this is while we're still within the kind of safety net of the government's furlough scheme. So this is research from the Northern Health Science Alliance and colleagues from the University of Manchester, looking at the unemployment rate during the pandemic in the northern regions, so that's the North East, North West and Yorkshire and Humber, compared to London and the rest of England. And we can see that London has the highest at around 8%, and then the North, the second highest at 7%. The rest of England is around 5.5%. So already, before, in a sense, the full impact of the economic crisis has happened, we can already see these regional inequalities, with London and the North, who, as you'll recall from my previous maps, were those most affected in terms of COVID-19 mortality. These same regions are having a double impact in terms of an economic crisis as well. And we know from the data and analysis that's been undertaken in the public health community in relation to the global financial crisis that recessions, depressions have unequal impacts on health. There's a very clear association shown here in work by Ben Barr from the University of Liverpool about the relationship between unemployment and suicides, particularly for men. As unemployment goes up, suicide rates go up. So we could expect that as unemployment rates go up unevenly across the country, then unfortunately suicide and the associated underpinning mental health impacts will also be unevenly geographically distributed. However, it's not the case that this is just how it has to be. It happened 100 years ago, it's happening now, what can we do? Research also tells us, international research, that the economic fallout and the inequalities that come from it can be mitigated by how governments choose to respond. And we saw this in terms of differences in countries who pursued an austerity route, such as the UK, Greece, Italy and Spain, compared to those countries such as Iceland or Sweden, who chose to maintain their social expenditure and their social safety nets. Countries with high rates of social protection had very little or no increases in health inequalities during economic recessions. And indeed, we have evidence from within England that inequalities can be decreased through the role of the state, particularly in terms of welfare expansion and investment in healthcare services. So this chart shows work around the impact of the English health inequality strategy that ran from 2000 to 2010. And it shows how the gap in trends of mortality amenable to healthcare between the most deprived and the rest of England fell as a result of this strategy. Similarly, this strategy, which increased investment in the NHS, brought in interventions for children in early years such as Sure Start, the minimum wage, and various investments such as family tax credits, also led to a decrease in inequalities in infant mortality rates. And as we saw after the end of the strategy and the change from an investment basis to an austerity basis, we saw an increase in infant mortality rates already. But this data shows that a sustained government intervention can reduce health inequalities. And so we do not just have to accept the inequalities in COVID-19, and we do not have to accept that inequalities in unemployment have to lead to further inequalities in health across the country. So to conclude, there were health inequalities pre-COVID were significant. For example, the average life expectancy gap between the north and south of England stood at 2 years. If we look at neighbourhoods, then the most deprived neighbourhoods, then men have a life expectancy of 7 years less compared to the most affluent. These health inequalities existed before the pandemic and are in turn resulting in an unequal pandemic. the COVID-19 outcomes are worse in less advantaged groups and communities. And I've argued that we need to think about this in terms of the framing of a syndemic, where we can think of the combination of existing NCDs, social and economic inequality, and the social determinants of health. We need to be mindful with the vaccination programme that we need to reach the most vulnerable populations so we can avoid it becoming an example of the inverse equity hypothesis. The economic crisis is concerning in terms of future inequalities. A social safety net, as has been shown through international and British research, can reduce health inequalities. But of course, in the longer term, to reduce having the poorest outcomes for COVID-19 in terms of, for example, in terms of Europe, then we need to have more concerted long-term action around the inequalities within existing clinical conditions so that we're better prepared to withstand any future health threats. Thank you very much for listening, and if you have interest in anything I've talked about, then these are some references, and I've co-authored a book which will be out next week with Policy Press. Thank you.
Thank you very much, Claire. That was enlightening, if not also quite distressing in places, about the fact that a lot of this was very predictable and based on things that you've been researching for years. I wanted to start off by asking you, given that we know that these have existed for a while, but do you have any hope that what COVID has highlighted about these disparities might catalyse some action and some improvements?
Yeah, I mean, I think one of the big things is that COVID has really highlighted to the world, but also to the public health community around the Black, Asian and minority ethnic inequalities, which were not particularly focused upon, I would say, within the health inequalities field. And so there's a kind of belated focus now on that, which is really important and valuable. We can also see how the COVID-19, the inequalities in it, had actually prompted some of the political action last summer as well. The Black Lives Matter movement was about more than police violence. It was also about health inequalities in a sense, and was kind of, I guess, exacerbated by the COVID context. So I think we can be hopeful that it's being, these different aspects of inequality are being taken more seriously within the wider public health community. So it's not just health inequalities researchers like myself and Vittal, but a wider audience, including your centre, for example, are now very aware and focusing upon health inequalities too.
Thank you, and thank you, Vittal, for rejoining the discussion. Please put any questions that you have for either Vittal or Claire in the Q&A, and we'll try and get to those. So what near-term actions do you think could mitigate the ongoing unequal impacts? Can you see anything that we're kind of missing a trick with as the kind of pandemic progresses? And I'm going to ask that of both of you.
I have one thought which I think is a bit of a no-brainer, to be honest. So at the moment, the UK has very limited access to sick pay, and I think that actually making sick pay more accessible, more generous, and preventing the disincentives that currently exist to support people to self-isolate, for example, if they're symptomatic, would be quite an immediate thing that could be achieved and changed. And actually it's likely to disproportionately benefit both lower socioeconomic groups and also ethnic minority groups as well. So I think, just as an example, but there's undoubtedly quite a few other things that should be being done.
Yeah, and just to pick up on that, it's interesting that if you're furloughed, you get 80%. But if you're a key worker and you need to self-isolate, you get statutory sick pay. You know, there's a big discrepancy there. Why not have 80% of your wage as your sickness absence? And again, it's another example of inequality where those of us in more professional occupations often have a better sick pay allowance. We're not dependent on statutory sick pay, for example, but get a more generous occupational payment that again makes it easier for us to self-isolate and to avoid transmitting onwards within our homes and communities. I think the other things we need to think about are around how we increase the vaccine uptake as well. And I know Professor Fenton mentioned that in his talk. Certainly, there's a lot of innovation going on in the North East region around this. For example, in terms of sending out mobile vaccination units into communities where the uptake's been particularly low. And again, as Professor Fenton mentioned, engaging in education and conversations with the communities to try and sway people's doubts, a lot of which is coming, through social media, for example.
I think you kind of touched on leading on to another question there. And to what extent do you think kind of policies trying to address this inequality should target specific ethnic communities as opposed to lower socioeconomic groups? And I suppose more broadly than that, how much should they be specifically targeted or more broader policies?
Well, if we look at the vaccine issue, then there is this intersection between deprivation and ethnicity. And, that's kind of not a surprise when we think about things like structural racism and discrimination within the labour market and so on. So I don't think personally that we should be targeting groups in such a specific way because of the stigma that can come from that. I do think that a geographical approach to targeting, for example, around vaccines is less stigmatizing potentially. Obviously there's still risks, but I think it's less so than pinpointing a particular group A and saying they haven't got high enough vaccine uptake, brackets, they're affecting the rest of us. To go out into geographical areas and say, actually, we need to boost it here is perhaps slightly less stigmatizing and could be more beneficial as well.
Yeah, so I would agree with that. So I do think what we know about kind of policies that generally are the most impactful in addressing health inequalities is they tend to be the things that don't require people to opt into them and aren't necessarily targeted. So often it's approaches that actually involve the whole population, but make things easier for everyone and might disproportionately benefit the most disadvantaged in society. So actually, for example, making healthcare services easily accessible is likely to help both ethnic minority groups and lower socioeconomic groups. There's the other thing that I think is worth reflecting on, I suppose, in light of the previous question, is the need to actually think about addressing these issues over a longer term period as well. So I think we're often always thinking about how do we address the immediate crisis, but increasingly we're beginning to understand that actually COVID is going to be with us for quite some time. So we do need to try to make sure that we're making our services and our policies much more sustainable as well, rather than actually just focusing on how do we get vaccination uptake improved in the next month. Actually, how do we engage communities so that they're taking the vaccine now, but also they're then likely to take a booster dose if it's required in, say, a year's time or whatever, keeping people on side and working with them over a longer term period.
Yeah, I mean, equally, I showed, past data on inequalities in, different pandemics, but we equally know that there's inequalities in other vaccines. So if you look at childhood immunisation, we look at measles, we look at the seasonal flu for the over 65s, there's always a gap in all of those between deprived and affluent areas. So again, it might come a bit of a shock to the politicians that not everyone's doing what they're told, sort of thing, but it is something that has been there, across. So I think reflecting what Vittal said, we can learn from these innovations because COVID's put us into a crisis management mode, so that, you know, vaccine uptake is now the source of daily debate, whereas previously, 2 years ago, it was only an issue to a minority of health workers and researchers. So we should be able to learn from some of the innovations from COVID to support vaccines in other areas.
Yeah, we can definitely hope that this new knowledge is actually catalyses some action and improvements. You hinted at this here in different vaccines against different diseases. So are there actually, is there any data behind mortality differences between ethnic groups for things like seasonal flu or other endemic infections? And was this actually part of the kind of pandemic preparation documents? Like, was this mentioned in advance of us?
So one of the things that the UK hasn't been great at is actually analysing data by ethnicity. So I think pre-pandemic, we often didn't routinely measure health outcomes by ethnicity. The limits of data that have looked at this have tended to suggest that things like respiratory infections and, say, hospitalizations for respiratory infections were either similar or often slightly lower amongst ethnic minority groups, at least in Scotland, where we looked at it. The part of the reason for that reflects something called the healthy migrant effect. So often when people move country, it tends to be the people who are the healthiest. And so often their health outcomes tend to be often quite good. Generally, my suspicion would be actually by ethnicity, many ethnic minority groups probably weren't being disproportionately affected by respiratory diseases. There's also often there are marked differences in things like rates of smoking and so forth, but in Scotland, white Scottish people tend to have quite high rates of smoking, for example, whereas some other ethnic minority groups have lower rates of smoking. So all of these things make quite a complicated picture. I think in relation to socioeconomic position, the picture there is much clearer, where often respiratory diseases and infections have consistently been higher. So yes, it's a slightly complicated picture. I'm not sure whether the government were necessarily had included thinking about ethnicity in their preparations, to be honest. I don't know.
Claire, you you demonstrated the really fascinating analogies with the 1918 pandemic during your talk. And that was kind of data for the North-South divide in the UK, but can you actually see these similarities country by country? Or has anybody looked into that?
In terms of how different countries fared in 1918?
Yes.
Yeah, I mean, obviously, some of the 1918 data is quite difficult for historians, but there's certainly suggestions that countries like Mexico and India had a horrifically bad Spanish flu pandemic. So just for listeners, then the estimate on total deaths for Spanish flu across the world was 50 to 100 million. So you can see there's a lack of specificity, but also you can see the scale was absolutely immense. And certainly, yeah, South Africa was another example that we know, given limited historical data, was another country we know did particularly badly. And again, that is, of course, looking like, certainly in India's case, that some of those patterns might be reflected today. And what's in common with that and with the UK example is that the underpinning structural inequalities globally and within our own country, on the face of it look like they're different places and they might have changed, but the reality is that there are significant underpinning economic and social inequalities then and now.
So a great question come in from Jenny Douglas. She said, I have argued in the past that research on health inequalities is focused on poverty and health, ethnicity and health, and gender and health separately. Why do you think this has been the case, and how are we going to develop intersectional research on health inequalities?
Yes, I'll just jump in, Vittal, if you don't mind. This is something that I've also thought about, particularly having my own mind shaped by what's happened with the pandemic. And I've very much kind of grown up within the British health inequalities community. And my gut, my personal view is that we are obsessed with class in Britain, or to a lesser extent geography. And what has shaped that whole community is the 1980 Black Report. And so in a sense, we're kind of in the shadow of the Black Report. And that was a report commissioned by the outgoing Callaghan Labour government in the late 70s. It reported in 1980, Bank Holiday Monday, under the Thatcher government, and was squashed. But it was the first government report internationally to really reveal the extent of social inequalities in health within a universal health system. So it's got a kind of foundational document role within the health inequalities community, and arguably that kind of what leads to a surge of research over the next 40 years or so. And that's all about class and to a lesser extent geography. So that would be my gut. I think if we look to other countries, and I think there's a slightly different twist where socioeconomic inequalities in health are much less talked about in the USA, and there's much more focus on what they would term racial inequalities in health. So that's my gut, but Vittal might have a different perspective.
Yeah, no, I think I would agree with that. The other thing I would say is, so I think most health inequalities researchers would agree that doing more intersectional research is really important, but practically it's very difficult as well. So if you're a more quantitative researcher, then often you run into kind of the limitations of the data you're working with. So if you want to, for example, cut the data by both ethnicity and socioeconomic position, you often run into just simple statistical power issues and that type of thing. So I think some of the opportunities that more of the kind of administrative data type studies provide might help us address some of that. But often many health data sets, at least, are often quite limited in the information they have about social characteristics. It tends to be a single measure of deprivation, and that's pretty much it. Even things like ethnicity are often quite poorly recorded. So I think some of it is the kind of more historical issues of how the field has developed, and some of it, I suspect, is also practical issues. And then the last thing that makes it a tricky area to do work on is if you're applying for research funding, you often then need to convince people from quite disparate perspectives of the work you're doing. So you might need to demonstrate how you're adding value to the field of ethnicity and health, and how you're also adding value to the field on socioeconomic position and health.
I suppose kind of in an ideal world, if you were to set up a data set from scratch, what kind of data are we missing that you would like to collect, that you think it's also ethical to collect on people around these kind of issues?
So I think, one area that we tend not to collect much information on at all is actually work-related factors. So issues, but actually, is someone employed? What job are they working on, and so forth? And especially when it comes to things like COVID, you can see how that has such immediate relevance. Similarly, we tend not to collect much in the way of information about households. So we often have information about individuals, but not actually the households they live in, which can be really important. There's often a disconnect as well with across government departments. So if we're interested in trying to understand the impacts of policies, so for example, what's the impact of income policies or welfare policies, or some of these big policies that we know have quite large impacts on health, especially for the most vulnerable in society, then that there are really quite substantial barriers to trying to look at that. So I think those are some of the big areas. But having said all that, I think in your question, you made the point about, well, how could we do this in a kind of safe and ethical way? Clearly, that's quite a topical issue in England at the moment in terms of some of the debates about NHS digital and making data available to the commercial sector for analysis. And I think given some of the data sharing that's happened between, say, the Home Office and the NHS, where undocumented migrants, for example, have been specifically targeted, then there might be some real substantial risks of trying to harness data without the appropriate safeguards in place. And I think the blurring the distinctions between health research and commercial exploitation is arguably quite risky.
I would agree with what Vittal said, but just to sort of take on a different perspective as well, is to think about what we mean by data set. And reflecting back on Jenny Douglas's comment around intersectionality, then I think some of the work that we need to do around that from a health perspective is to draw on, sociology, social geography, and to draw on more qualitative methods of data collection, because I'm not always convinced that we can condense people's experiences and multiple aspects of their identity that shape that experience into a single odds ratio or whatever it might be. And that's not to say that it's not useful to do so, as Vittal knows, but as a mixed methods researcher, I think it's also important that we're able to bring in that experiential and that maybe that actually for some of the logistical reasons Vittal's mentioned, but also I guess in a sense a kind of different epistemological ethics, that it would be useful to use qualitative research as well. And in fact, Vittal and I are involved in a project led by Peter Craig at University of Glasgow, evaluating universal credit, which does try to take these different methods together to capture a more nuanced understanding of the inequalities impact of that particular policy.
Great. On a kind of a shift in note, actually, I've had another question in about, unfortunately, there seems to be a lot of misinformation circulating on the internet about both the pandemic and vaccines over the past year. In what ways do you think the scientific discourse in the media, and including social media, may have impacted on health outcomes such as vaccine uptake?
I guess for me, it's not really my area of research, but so it was more a kind of speculative comment. But it seems difficult to think that those sort of how people see that on a much more daily basis, how that can't have some impact. And certainly I think from Professor Fenton's presentation, he was saying about some of the efforts Public Health England are doing to counter that, which suggests that Public Health England do think it is an issue that needs to be tackled. And we can also see efforts, for example, in France in trying to tackle their kind of anti-vax movement.
Yeah, I think that's right. I think the other thing as well is how we as researchers try to communicate information in a kind of fair and transparent way, especially when evidence emerges on potential side effects and so forth related to vaccines, which have typically been very, very rare side effects, which are very small, but actually trying to convey that nuance, especially in the context of social media, where the messaging is often kind of geared towards being quite immediate, and there's a tendency to kind of amplify messages that are kind of arguably more controversial as well. The last point just to say about social media is, and the vaccine has the kind of anti-vax rather movement in general, is the potential scope, I suppose, for kind of commercial conflicts of interest as well. So there is some evidence to suggest that actually there might be some people who gain from the kind of negative discourse around vaccines and the kind of anti-vax movement. So it's not a totally neutral field with everyone just presenting their own honest views. There might be some people who actually have a kind of a commercial interest in propagating anti-vax messages.
And I think also for some different groups, there could also be a political motivation. And again, speculating a little bit, but I'm thinking over the last, couple of weeks ago, for example, there was a lot in the mainstream media about low vaccine uptake in Bolton and Blackburn amongst ethnic minority groups, right? And a lot of that was, to me, quite stigmatizing in terms of how it was presented around those communities. And of course, they also have been bombarded with anti-vax messages in various ways. And so it makes me think, well, are there political motivations for some of this social media as well as commercial ones? I think more broadly, what we need to think about is what COVID has shown in a kind of political sense is where some communities and some countries have much lower trust in their governments, in their healthcare providers, in the establishment, etc. And again, have to keep harking back on it, but these are things that will require long-term action. Yes, we need to solve it immediately because of the pressure of COVID, but we also need to solve it in terms of, whether people accept their health visitors or whether they see a midwife. All across the entire health and care system is impacted by whether people trust that system and that it's there for them. So messages certainly getting around in particular communities. For example, Professor Kate Pickett at University of York was telling me about things that were happening within Bradford that they'd picked up through their Born in Bradford study around very targeted social media posts for the Bradford community. So there's something going on which may be commercial and or it may be political, and of course it's really worrying.
Great. Sadly, I'm going to have to bring this to an end, but thank you very much for all of our speakers in this session for some absolutely fascinating insights. I think what you very clearly highlighted is this is an incredibly complex issue, but one that we need to keep working on, not just through the pandemic, but also into the future.